Indications. CABOMETYX, cabozantinib, in combination with nivolumab, is indicated for the first-line treatment of patients with advanced renal cell carcinoma, RCC. CABOMETYX is indicated for the treatment of patients with advanced RCC. CABOMETYX is indicated for the treatment of patients with hepatocellular carcinoma, HCC, who have been previously treated with sorafenib. CABOMETYX is indicated for the treatment of adult and pediatric patients 12 years of age and older with locally advanced or metastatic differentiated thyroid cancer, DTC, that has progressed following prior VEGFR-targeted therapy and who are radioactive iodine refractory or ineligible. Select important safety information. The full prescribing information for CABOMETYX includes warnings and precautions for hemorrhage, perforations and fistulas, thromboembolic events, hypertension and hypertensive crisis, cardiac failure, diarrhea, palmar-plantar erythrodysesthesia, hepatotoxicity, adrenal insufficiency, proteinuria, osteonecrosis of the jaw, impaired wound healing, reversible posterior leukoencephalopathy syndrome, thyroid dysfunction, hypocalcemia, and embryo-fetal toxicity. Please see important safety information at the end of this video.
Hi, I'm Dr. Kirollos Hanna, the Director of Pharmacy Services at Minnesota Oncology.
And I'm Dr. Joshua Strauss, a community hematologist-oncologist in New Jersey. Today, on CABOMETYX in Conversation, we're going to examine several cases. Instead of discussing our treatment decisions, we'll focus on how we practice in our clinics when initiating CABOMETYX and managing dosing to help optimize outcomes, particularly regarding side effects, safety, and tolerability.
We'll go through cases in each indication: advanced renal cell carcinoma, hepatocellular carcinoma, and metastatic differentiated thyroid cancer. Dr. Strauss, this is where I have most of my experience with CABOMETYX.
I've used it mostly in advanced RCC and HCC, but I believe that the adverse reaction management experience gained through dose adjustment can potentially translate to other approved indications when using CABOMETYX.
Yes, a lot of it has really been about setting a patient's expectation up front and then managing through an AR to keep a patient on therapy. However, it's important to note that not all side effects are manageable.
I totally agree. So let's get into it. CABOMETYX was first approved in advanced RCC, and that's the most common tumor type of the three we'll be talking about.
Our hypothetical patient, Andrew, is a 56-year-old man who presented with a 5-centimeter right renal mass, which a biopsy revealed to be clear cell advanced RCC. 12 months after a partial nephrectomy, Andrew reported experiencing shortness of breath, and subsequent imaging showed bone and lung metastasis.
And he was started on CABOMETYX and Opdivo for his first-line treatment?
He was, and something I like about CABOMETYX for someone like Andrew is that it's only one pill once a day.
Yes, he gets an Opdivo infusion every 2 or 4 weeks, and he may be on other medications, either to help control comorbidities or for pain. Some of those medications, especially diuretics and blood pressure medicines, can require significant titration to find the right dose. Not to mention, it's essential to regularly monitor patients' blood pressure during CABOMETYX treatment. Additionally, you often need to consider that CYP3A4 inducers and inhibitors may impact the dose.
That is true. With CABOMETYX, I appreciate having a treatment that is a single tablet taken daily. In this combination regimen, it is one 40-milligram pill once a day. There's no need to create a dosing calendar with CABOMETYX. Both my staff and patients like that as well.
Now, let's talk about another hypothetical patient, George. He initially presented with abdominal pain and weight loss, and CT scans revealed at least 4 nodules in his liver and lung metastases. After a biopsy, he was diagnosed with unresectable advanced HCC and treated with sorafenib for 7 months. At that point, he developed extrahepatic spread and had signs of mild cirrhosis.
He was initiated on CABOMETYX at that point. In HCC, the starting dose is 60 milligram rather than the 40 milligram that's used when CABOMETYX is given in combination with Opdivo for first-line advanced RCC in Andrew's case.
If George's liver function worsens to Child-Pugh B, his starting dose will actually be reduced to 40 milligrams once daily, as the CABOMETYX prescribing information recommends.
Adjusting the starting dose is something you have to do if a patient is on a strong CYP3A4 inducer or inhibitor as well.
And his dose may need further modifying from there, which can be a part of the treatment process. When I start someone like George on CABOMETYX, I let them know this is where we'll start and advise finding a consistent time, either at least 1 hour before or at least 2 hours after meals when they can take it every day.
But otherwise, I consider these things across all approved indications. For our third case, let's talk about a hypothetical patient named Sarah, a 62-year-old female who presented with a thyroid nodule and palpable adenopathy. A biopsy confirmed a 4.5 centimeter papillary thyroid cancer. She was diagnosed with metastatic differentiated thyroid cancer and proved to be radioactive iodine refractory. She was subsequently treated with a VEGF receptor targeted therapy, but progressed thereafter.
At which point, treatment with CABOMETYX 60 milligrams once daily was initiated.
Now, Sarah has some comorbidities that may impact side effects, so I believe some dose adjustments may be needed to find the right dose for her.
Yes, that's something I try to emphasize to Andrew, Sarah, and George. Dose adjusting may be part of using CABOMETYX, and that's okay. Dose modifications were part of all the pivotal trials, and efficacy seen in those trials was achieved in the context of dose modifications. In the CheckMate 9ER trial of advanced RCC patients, 83% of patients receiving CABOMETYX or Opdivo experienced dose interruption or reduction versus 72.5% in the sunitinib group. In the HCC Celestial trial, 84% of patients had their CABOMETYX dose withheld versus 37% with placebo, and 62% of patients experienced a dose reduction versus 13% with placebo. And in the DTC Cosmic 311 trial, 72% of patients receiving CABOMETYX had their dose withheld versus 27% with placebo, and 56% experienced a dose reduction versus 5% with placebo.
And I find the dose reduction schedule to be similar across CABOMETYX indications. For symptomatic ARs, I pause treatment and monitor until that AR resolves to grade 1 or a tolerable level. Then resume therapy at the next lower dose level. In some instances, we may need to discontinue CABOMETYX permanently. Do you find your patients are resistant to dose modifications and lowering the dose?
It can depend. Different patients have different treatment goals. Some are focused on survival. They can be reluctant to have their dose reduced, or they can feel like they failed. Others are more focused on the tolerability of their treatment and are okay with dose reductions. What I find to be important is educating patients about dose modifications up front. We have to prepare our patients that dose modifications are to be expected, and they are a normal part of continuous therapy.
Counseling patients is definitely important for keeping patients on therapy. This includes informing patients about the most common ARs so they know what to look out for and are not surprised if they get them. In terms of CABOMETYX, I talk about hypertension, diarrhea, and PPE, and how we will manage through them if they occur. I tell them it's unlikely they'll get all of the listed side effects, but it's also unlikely that they won't get any of them.
Yes, that's what I talk about with my patients as well. They'll experience some ARs, but it's okay. Don't be surprised, and we'll help manage it. I also ask them to please not wait until things are at their worst to call me. I ask them to tell me when they first start to notice their symptoms, so we can talk it through and get ahead of it. It's important to note that not all side effects are manageable.
I encourage my patients to keep symptom diaries. If they can document when symptoms occur, how many diarrheal movements they're having a day, that could help us help them manage those ARs.
I sometimes ask them to take pictures of their hands so I can track any PPE.
It's a great idea.
Also, when I do need to modify a dose, I've found the dose exchange program to be helpful for eligible patients. I had a patient who had just refilled her 60 milligram dose, but she started to experience hypertension, and we needed to hold therapy before dose reducing to 40 milligrams. The program's designed to help people like her switch to a lower dose, and it did exactly that.
Of course, sometimes you do have to discontinue treatment.
Certainly, that's a potential outcome, but I find the trial data with CABOMETYX encouraging. In the CheckMate 9ER trial of advanced RCC patients, the discontinuation rate for CABOMETYX alone was 8%. In the Celestial trial of advanced HCC patients, it was 16%. And in the metastatic DTC trial, COSMIC-311, it was 5%.
So in summary, for Andrew, George, and Sarah, we both like that CABOMETYX is one pill once daily, and we both find dose modifications to be relatively simple.
And we both believe in the importance of counseling patients to anticipate the most common adverse reactions and in preparing them for dose modifications to be a part of the journey.
Because the results seen in the CABOMETYX pivotal trials occurred in the context of dose modifications, appropriately withholding CABOMETYX, then reinitiating it at a lower dose can help patients stay on therapy longer.
Exactly.
Well, thank you so much for talking about all this with me. It was great to get insights into how you think about this.
Likewise, it was great speaking with you. And if people are interested in learning more about other hypothetical cases and how we and our peers evaluate treatment approach, please check out other videos in the CABOMETYX in Conversation series.
Important safety information, warnings and precautions. Hemorrhage. CABOMETYX can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in CABOMETYX patients in RCC, HCC, and DTC studies. Discontinue CABOMETYX for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of CABOMETYX patients. Monitor for signs and symptoms, and discontinue CABOMETYX in patients with grade 4 fistulas or GI perforation. Thromboembolic events. CABOMETYX can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of CABOMETYX patients. Fatal thrombotic events have occurred. Discontinue CABOMETYX in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. CABOMETYX can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of CABOMETYX patients. In CABINET, N equals 195, hypertension occurred in 65%, 26% grade 3 of CABOMETYX patients. Do not initiate CABOMETYX in patients with uncontrolled hypertension. Monitor blood pressure regularly during CABOMETYX treatment. Withhold CABOMETYX for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue CABOMETYX for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. CABOMETYX can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with CABOMETYX as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. CABOMETYX can cause diarrhea, and it occurred in 62%, 10% grade 3 of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold CABOMETYX until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar plantar erythrodysesthesia, PPE. CABOMETYX can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold CABOMETYX until PPE resolves or decreases to grade 1, and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Hepatotoxicity. CABOMETYX in combination with nivolumab in RCC can cause hepatic toxicity with higher frequencies of grades 3 and 4 ALT and AST elevations compared to CABOMETYX alone. With the combination of CABOMETYX and nivolumab, grade 3 and 4 increased ALT or AST were seen in 11% of patients. Monitor liver enzymes before initiation of treatment and periodically. Consider more frequent monitoring as compared to when the drugs are administered as single agents. Consider withholding CABOMETYX and/or nivolumab, initiating corticosteroid therapy, and/or permanently discontinuing the combination for severe or life-threatening hepatotoxicity. Adrenal insufficiency. CABOMETYX, in combination with nivolumab, can cause primary or secondary adrenal insufficiency. Adrenal insufficiency occurred in 4.7%, 15 out of 320, of patients with RCC who received CABOMETYX with nivolumab, including grade 3, 2.2%, and grade 2, 1.9% adverse reactions. Withhold CABOMETYX and/or nivolumab, and resume CABOMETYX at a reduced dose depending on severity. Proteinuria. Proteinuria was observed in 8% of CABOMETYX patients. Monitor urine protein regularly during CABOMETYX treatment. For grade 2 or 3 proteinuria, withhold CABOMETYX until improvement to less than or equal to grade 1 proteinuria. Resume CABOMETYX at a reduced dose. Discontinue CABOMETYX in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. CABOMETYX can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to CABOMETYX initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold CABOMETYX for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold CABOMETYX for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. CABOMETYX can cause impaired wound healing. Withhold CABOMETYX for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of CABOMETYX after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. CABOMETYX can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue CABOMETYX in patients who develop RPLS. Thyroid dysfunction. CABOMETYX can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of CABOMETYX and monitor for signs and symptoms during treatment. Hypocalcemia. CABOMETYX can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of CABOMETYX patients, 2% grade 3 and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume CABOMETYX at a reduced dose upon recovery, or permanently discontinue CABOMETYX depending on severity. Embryo-fetal toxicity. CABOMETYX can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with CABOMETYX and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are CABOMETYX as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. CABOMETYX in combination with nivolumab, diarrhea, fatigue, hepatotoxicity, PPE, stomatitis, rash, hypertension, hypothyroidism, musculoskeletal pain, decreased appetite, nausea, dysgeusia, abdominal pain, cough, and upper respiratory tract infection. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the CABOMETYX dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the CABOMETYX dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during CABOMETYX treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the CABOMETYX dosage. Avoid CABOMETYX in patients with severe hepatic impairment. Pediatric use. Physial widening has been observed in children with open growth plates when treated with CABOMETYX. Physial and longitudinal growth monitoring is recommended in children 12 years and older with open growth plates. Consider interrupting or discontinuing CABOMETYX if abnormalities occur. The safety and effectiveness of CABOMETYX in pediatric patients less than 12 years of age have not been established. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.